a doctor part-time clinically and part-time as an editor at Quesmed. So today we're going to be talking about single best answer questions in urology. So the format of this lecture is going to be single best answers. So normally we have polls up, but we can't work the polls. So if you want to answer the questions, it'd be great if you could pop a wee answer in the chat box, or at least note down your answer so that you're kind of thinking in exam mode, thinking about what you would put if it was a real life exam situation. So this lecture content is by Santosh. I'm just delivering that on behalf of them. So obviously this is copyright of Quesmed. This lecture is recorded, so don't worry if I'm going through this too fast. It will be pop on YouTube later on in the week, so you can go back and pause and record, go through the questions again as you wish. So I'm not sure why this is moving on without me clicking anything. So I'm just going to crack straight on with question one. So I'm going to give you 60 seconds to read the question, and if you want to, you can pop an answer in the chat box or note an answer down for me. So normally I give you 60 seconds because that kind of reflects what you would have in a single best answer exam. So pop a wee answer in the chat box if you want to, or note your answer down, and we'll have a wee chat about that after. Wonderful. So thank you so much for people who answered there. Thank you. It's very helpful. So what do we have here? We've got a young boy. We've got sudden onset unilateral scrotal pain, which has occurred overnight. Sounds pretty significant. He's been woken up from his sleep. He's vomiting. His right testicle is enlarged. It appears to be higher than the left. And we also note that the cremasteric reflex is absent. So the question is asking what is the most likely diagnosis here? And the correct answer here is testicular torsion. So thank you for those that answered. You all got the answer correct. So well done. So let's talk about testicular torsion. So this is a urological emergency, and this is probably the thing that's asked about most in exam questions, as it is obviously an emergency. Now, it's more common in children and young men. And thinking about symptoms and signs, so a severe sudden onset pain in one testicle or one side of the scrotum, and tenderness on examination. Classically, the testicle will be higher than the other one. Obviously, some testicles are higher than the other. That's perfectly normal, but you'd feel like this is significantly higher, and that would be a new finding for the person. And other things you might find on examination is even on elevation of the scrotum, that's not relieved. You'll find that the testicle or the scrotum is swollen, and vomiting is really, really common in testicular torsion, particularly in children. And the cremasteric reflex, do we all remember what that is? So that is the elevation of the scrotum on touching the inner thigh. So you'll find that is absent in testicular torsion. And that's sort of a very common exam question, is asking about cremasteric reflex, so worth remembering. So let's move on to the next question here. Again, I'd be super grateful if you pop a wee answer in the chat box for me. Perfect. So again, thank you so much for answering. You guys are super quick, which is great for exam technique. Because obviously when you're doing single best answers, you sometimes only have a minute or so per question. So well done there. And this is a sort of similar story, isn't it? We've got a 12-year-old boy. He's got sudden onset unilateral pain. And this wee guy, he's not letting people examine him at all. However, this question is not asking for the diagnosis, which is likely testicular torsion, as in that first question. It's asking about the most likely immediate complication. And the correct answer here is testicular infarction. So let's talk a bit more about testicular torsion and how we manage that. So immediately we want to relieve symptoms. So it's really important to give these people adequate analgesia and antiemetics if they are vomiting. And as I said, this is an emergency. This requires immediate urological review. And normally what these patients will proceed to is a scrotal exploration and a manual detorsion of the testicle. In terms of complications, the ones we worry about is ischemia, so tissue being deprived of an oxygenated blood supply, and necrosis, which is dead tissue. And the associated complications with that are obviously infertility if we're losing a testicle. What we also worry about is if we do have to perform an orchidectomy, so if we do have to remove the testicle entirely, there's significant psychological issues that surround that, and obviously the cosmesis of only having one testicle. And the most common complication with people that have testicular torsion is they tend to tort over and over again. And actually there's some preventative surgery that can be performed to stop torsion from happening again. So these are the complications that we think of. So the correct answer to that question there is testicular infarction. We worry about a dead testicle essentially. So that's why it's really important to get this reviewed by urology ASAP, and the reason why it is a urological emergency if you see this in A&E or in GP. So moving on to the next question, again, I'll give you 60 seconds. Thank you so much for answering. So a bit of a mixed bag there. We're not sure what the correct answer is there. So what have we here? We've got a 45-year-old man who's come into A&E. He has a sudden onset of right-sided flank pain radiating to his groin. And he's describing this pain as coming in waves. On an examination, the patient is writhing in pain and he can't get into a comfortable position. He's also vomiting and he looked clinically dry. Now, he denies any recent trauma and he's able to walk about. He just can't get comfortable. So the correct answer here is renal stones. So sudden onset flank pain coming in waves is characteristic of renal colic. Coupled with the vomiting, coupled with this writhing in pain, not able to get comfy, this points towards renal stones. So this classic loin to groin pain is characteristic of renal stones. And this coming in waves is what we call colicky pain. And that is really characteristic of renal stones essentially. Checking in with the other answers here now, testicular torsion, we've already been over that. Now there's no mention of any testicular findings here. There's no mention of testicular pain or anything like that. So I'm not convinced it's a testicular torsion. Biliary stones, yep, that can also present with this pain coming in waves, this colicky pain. However, in biliary stones, it's more likely to be in the right upper quadrant rather than this loin to groin pain that he's describing. A neck of femur fracture, that's going to be extremely unlikely in a 45-year-old man with no recent trauma and he's able to walk about. Neck of femur fracture would be extremely unlikely here. And appendicitis, now that would be my other differential here. And that's a very, very valid differential. However, that usually presents slightly differently. So normally appendicitis is a vague abdominal pain, maybe starting in the center of the abdomen, moving over to the right side. tends to not be coming in waves so much and tends to not be radiating to the groin so much. And it tends to not be so sudden in onset. So appendicitis usually comes on quite insidiously, sometimes with a vague abdominal pain and then localizing to the appendix. So the history here is not quite appendicitis, but I absolutely valid differential, and that would be one of my top diagnoses that I'd want to rule out. So well done, guys, for answering. And I can very much see why you put appendicitis, but in this case, I'd say renal stones is slightly more likely, just given the history of the pain being loin to groin and coming in waves, it's colicky. So moving on to the next question, again, I will give you 60 seconds. Wonderful, thank you for answering here. So here we've got a young girl, she's 23 years old, and again, she is presenting with this sudden onset flank pain radiating to the groin. Surprise, surprise, she's also vomiting. Everyone is vomiting today, unable to keep anything down. So on examination, she has that characteristic, she is unable to get comfortable, she's writhing around. She's also tachycardic and she's got a temperature, mild pyrexia, 37.9. She's already on intravenous fluid, she's already been referred to urology, and someone has thankfully already done a urinary pregnancy test, because that is one of the things we'd want to do in a woman of childbearing age here. Now the question is asking, not asking what's the diagnosis, but it's asking what the most appropriate analgesia is. So the diagnosis here I think is probably renal stones. She's got that classic loin to groin pain, she's got that writhing around, she's got that vomiting, it's sudden of onset. So very much renal stones type pain. But the question is asking, what do we give her in terms of painkillers here? So the correct answer here would be diclofenac per rectum. And the reason why is because NSAIDs, so things like ibuprofen, diclofenac, are particularly good for treating renal stones. But oral anything is not going to be very effective in this woman here. She's vomiting, she's not able to keep anything down. So we can immediately discount things like oral ibuprofen, oral paracetamol. She's allergic to opioids, so we better not give her morphine. An epidural, that's a bit extreme. We usually reserve epidural anesthesia for obstetric people. And that is usually also opiate based, so we want to avoid that. So the only appropriate option here would be diclofenac, and we do use diclofenac rectally very often in treating renal stones. It's very effective. So having a bit more of a chat about renal stones. So thinking about risk factors, obviously dehydration is a risk factor. People that have a high salt diet, people that are obese, and most importantly, people that have had previous renal stones. And stones come in a few different forms. So the most common type is calcium based. And these are primarily either calcium oxalate, which is the most common, or calcium phosphate, which is slightly less common. Other types of stones, uric acid, cystine, struvite. For bonus points, and this is some of the exam questions that you might find in the kind of top 90% of students here, is asking about the risk factors for specific types of stones. So for calcium oxalate, we're thinking about any condition that causes a lower urine volume, hypercalcemia, obviously that seems self-explanatory, and hypocitrullia. Calcium phosphate stones, they are more common in people that have renal tubular acidosis and hyperparathyroidism. Uric acid stones, these are common in people that have a low pH in their urine, so a pH of less than 5.5. Cystine stones, they are super rare, but we want to think about those in people that have cystinuria, which there's a common autosomal recessive condition that causes that. And interestingly, struvite stones, now they're more common in people that have infections associated with Pseudomonas or Klebsiella. I can see someone's asking in the chat there, why do we give it per rectum? Now, we can give diclofenac orally, however, it's very well absorbed per rectum, and this person was vomiting, so it seems sensible to give them it in some other route apart from oral. So rectal diclofenac is an absolutely great drug for renal stones. It's well absorbed, it acts quickly, and it's not affected by vomiting. So that's the reason we would go for that in that case. In terms of presentation of renal stones, this is the classic severe acute renal flank pain. So we call that renal colic. So colic is a medical term for kind of pain coming in waves. And that is associated with the waves of peristalsis that happens in the ureters. And classically, it is loin to groin pain. So flank radiating down into the loin, the groin, sorry. And classically, these patients, they are writhing around, they are not able to get comfortable, they're kind of rolling around in the bed, walking about, bent over. Vomiting is super common in renal stones, and when you do a dip, you might see hematuria, microscopic hematuria. The urine might be visibly hematuric. And renal stones can also cause kind of urinary tract infection type symptoms, so things like frequency, urgency. So do bear that in mind when you're wondering about renal stones. In terms of investigations, the preliminary ones you want to do as soon as you see the patient is a urine dip, plus or minus the pregnancy test for any women of childbearing age. We're looking for things like, we're looking for white cells in the urine, we're looking for nitrites as a source of infection, and we're looking for hematuria. We also want to do bloods. We want to look for inflammatory markers. We want to look at the white cell count, the CRP, and we want to look at urea and electrolytes. We want to check kidney function. Does this person also have an acute kidney injury? And a CT-KUB, so a CT of the urinary, kidneys, ureters and bladder, is the diagnostic investigation for renal stones. However, quite often we'll do an ultrasound first. Now, an ultrasound might not show the stone, but it might show if the stone is causing an obstruction or it's causing a dilatation of the ureters. And in particular, we would avoid CTs in anyone that is pregnant. In terms of initial management of renal stones, now initial management is hydration and analgesia. Hydration is really important, so get these patients on IV fluids if they're not able to maintain oral intake, and analgesia, and we've already spoken about that, so non-steroidals are really, really good. And if the patient's able to take opiates, opiates are also good analgesia for renal stones. Now, if the stones are small and there's an arbitrary cutoff of 5 millimeters, they may pass spontaneously. So it may be that all that is required is hydration, analgesia, and observation. Obviously, if the patient is pyrexial, if their inflammatory markers are up, we would treat them as sepsis with antibiotics. If the stone is found to be of an arbitrary cutoff of greater than 10 millimeters, we normally need to remove that. So that is either with lithotripsy, which is by shock waves, or by percutaneous nephrolithotomy, which is essentially poking a hole in the skin to get to the kidney to retrieve the stone. Staghorn calculi, these seem to come up often in exam questions. They seem to be a favourite to be asked about. And these are large, multifaceted stones, and they take the shape of the kidney. So you can see that picture on the left there, that is taking the kind of shape of the renal calculi. And obviously that is not going to pass spontaneously. And these almost always need removal. And they're actually associated with a higher level of complications of renal stones. So talking about complications, I've already mentioned renal stones can present as sepsis and should always be treated as sepsis in the presence of pyrexia, inflammatory markers, etc. These stones can scar the ureters, they can cause strictures, which can cause an obstruction in itself. Renal stones can also cause an acute kidney injury, hence why we want to check the bloods for their U's and E's, make sure their kidneys are functioning properly. And the most common complication is simply that they recur. So people that have kidney stones tend to have more kidney stones, unfortunately. In terms of your differential, so there's many things that are presenting similarly to renal stones. The most common one is probably appendicitis, which I can see why some of you picked to the previous question. Other things that you can mistake renal stones for is ectopic pregnancy, hence why we do that urinary pregnancy test. Things like ovarian cysts, pancreatitis, torsions, musculoskeletal back pain, So in any case where you think it might be renal stones, it's really important to take a good history, to order the right investigations, make sure you've got everything ordered so that you've got a bit of information to work with so you can come to the correct diagnosis. So moving on to the next question, again, I will give you 60 seconds. You guys are great. Thank you so much for answering. So what have we here? We've got a 50-year-old man. He's went to his GP and he's got a 2-day history of burning when he's peeing. He's not reported any blood, but he does say that he's going to the loo more often, and he does have some mild suprapubic tenderness. So we do the first investigation, which is a urine dipstick, and we find it's positive for leukocytes and nitrites. I'm not sure I would have jumped to a digital rectal examination, but we've done one and that's normal, so that's good. And the question's asking what is the most likely diagnosis. So the correct answer here is a lower urinary tract infection. So well done, guys, who got the correct answer there. So lower urinary tract infection. So clinical symptoms, these involve the bladder, the urinary sphincter, the urethra, and in men, the prostate. And I find it quite helpful to sort of divide symptoms into irritative symptoms and voiding symptoms. So the symptoms related to irritation, these are just to do with having an angry bladder. The bladder is irritated, the bladder is angry, and it causes symptoms such as frequency, urgency, urgent continence, and nocturia. Then we have voiding symptoms, or obstructive symptoms, and these are problems passing urine. So things like a poor stream, hesitance, dribbling, retention, overflow, incontinence, and these are to do with the urethra being irritated and swollen and not allowing the passage of urine. So common causes and underlying things that we want to think about is things like benign prostatic hypertrophy, BPH, bladder stones, kidney stones, cancers, detrusor muscle problems, diabetes, neurological, drugs, infection, strictures. There's lots of causes of UTI, and particularly in men. So UTIs are quite uncommon in young, fit, healthy men. So we would want to think about is there an underlying cause of a UTI in men. And thinking about investigations here, so urinalysis is the most common preliminary investigation. We want to look for leukocytes and nitrites, and leukocytes and nitrites in the presence of symptoms is pretty diagnostic of a UTI. And anyone that has a positive urinalysis, we would send their urine for culture and sensitivities. Other investigations we might think of is bloods, so checking their U's&E's, checking their inflammatory markers. We might want to ultrasound the bladder just to check for any structural abnormality, particularly if we're worried about a cancer. Ultrasound is a good first investigation. And potentially urinary flow studies, if this is a long-standing problem, if they're prone to UTIs. And a prostate biopsy if we did find anything abnormal in examination, since we've done our digital rectal examination. So those are the main investigations for lower UTI. So moving on to the next question, again, you'll have 60 seconds. You guys are rapid. Thank you for answering. So what do we have here? We've got a 78-year-old man. We know he's got prostate cancer, but he's come to the emergency department with lower abdominal pain. And he says he's not passed urine for 10 hours and he is not able to void. And we've examined him and we find a distended bladder, which is causing him severe discomfort when palpated. If anyone has palpated a distended bladder, the patient's not usually very happy about that. So yeah, that will be painful for him. And the question here is asking which bedside test can be done to confirm the diagnosis. So key is in reading all of the words of the question there, a bedside test. So we can immediately discount a CT of the abdomen and an X-ray of the urinary tract, because we wouldn't normally do those at the bedside. And the correct answer here is a bladder scan. So I'm just going to move on to the next question and then I'll have a wee chat about the diagnosis itself. So I'll give you another 60 seconds. Perfect. Thank you so much for answering, and your timing is fantastic. You guys are great to stick into the 60 seconds. So what have we got here? We've got an 84-year-old man, so an older man this time, and we know that he has benign prostatic hypertrophy, so BPH. And he's the same. He has presented with sudden onset lower abdominal pain and distension. He has also not been able to pass urine. And this time we have done the bladder scan. So we've done that bedside test and that has revealed that he has a litre of urine in his bladder. So no wonder he is uncomfortable. And he's becoming more agitated. He is tachycardic. He is clammy. And the question is asking, what is the most appropriate immediate treatment option? And the correct answer here is, of course, a urethral catheter. So talking about acute urinary retention, which these two gentlemen have, essentially that's an inability to pass urine of any cause. So common causes are things like benign prostatic hypertrophy, so BPH, that is an enlarged prostate, things like infection, things like constipation. It can also be iatrogenic, so certain medications that we give can also cause urinary retention, and neurological causes, so anything that's affecting the nerves can affect the bladder function. And it tends to present with sort of lower abdominal pain, discomfort, and a palpable bladder. In the elderly, it can also present with simply agitation. So in older people, particularly people with dementia that might not be able to communicate what's wrong with them, placing a hand on the belly, feeling for the bladder, perhaps even doing a urinary catheter or a bladder scan is really important in the elderly. And an agitated elderly person, we do not want to miss a urinary retention. In terms of investigations, we want to think about doing a urinalysis plus or minus culture when we do get a urine sample. We do want to obviously do a urethral catheter. We would go for urethral first if we're able to pass that, as that is much easier to insert. Any FY1 can insert a urethral catheter. So we wouldn't immediately go for a suprapubic catheter if we can pass a urethral one. You can pass an enlarged prostate usually fine. We wouldn't go for suprapubic straight away. I don't know any FYs that can do a suprapubic catheter, so that would involve, phoning urology, finding someone that can do that. So I'd go for urethral first. If you cannot pass a urethral catheter, you would absolutely go for suprapubic. And we want to scan them again after we've inserted that catheter. Have we relieved that full retention? Is there any urine left in the bladder? And actually putting in a urethral catheter for someone that's in retention is quite a satisfying thing to do, because you almost immediately relieve the retention, you relieve their pain, and they are much more comfortable. Other things we think about is things like bloods. So has this all caused a urethral, an AKI, acute kidney injury? We might want to thinking about why they've gone into retention. So do they need an ultrasound to look at their kidneys, to look at their ureters? We also want to think about, if we don't know their history, do they have an enlarged prostate? So like Priya said there, the only excuse for not doing a digital rectal examination is if you don't have fingers or if they don't have a rectum. So please do PR the people that are in retention and you don't know why. And management is obviously catheterization, and of course treating the underlying cause, whether that be an enlarged prostate, whether that be an infection, whether that be they're on too many medications, treating the underlying cause. And complications of retention, so it can cause an acute kidney injury, hence why we want to check their bloods for the U's and E's. It can cause infection. Obviously, if you've got stagnant urine sitting in the bladder for hours, that's not great from an infection point of view. Complications can be they might have renal stones, and they may have been in retention for quite a long time, so they can get a condition called post-obstructive diuresis, where we get rid of so much urine that they're actually diuresing too much. So these are the common complications of retention, but usually once you've relieved that retention, the patient usually improves dramatically quite quickly. So moving on to the next question there, we're almost there, guys. I'll give you another 60 seconds. Thank you so much for answering there. So some people think A, some people think B. So what have we got here? So we have an elderly gentleman. He's got some red flag symptoms. So he's got some weight loss, he's got some back pain, and he's got frequency. I presume that means urinary frequency. We've done our digital rectal examination and that is suspicious. The question doesn't specify suspicious what for. However, he has gone to urology. A urologist has seen him, and we now know that he has a high-grade prostate cancer. And the question's asking what scoring system we might have used to make the diagnosis here. So the correct answer here is the Gleason score. Thinking about the other answers there, because a lot of you put A. So the International Prostate Symptom Score, the IPSS, that is used to ask about symptoms of prostate cancer. So it asks about things like emptying, frequency, intermittency, urgency, if they've got a weak stream, if they've got straining, nocturia, things like that. It is to grade symptoms. So you wouldn't make a diagnosis based on that. That's more for monitoring and seeing how a patient's getting on once we know they have a prostate problem. The correct answer here is the Gleason score, which is a specific scoring system used for prostate cancers. Do we remember what Jukes is for? So Jukes, that says to me more a bowel cancer. It's Jukes scoring system that's used to score kind of bowel cancers. The Glasgow scoring system, so for that, I would think about the Glasgow Coma Scale, or perhaps the Glasgow Emery scoring system for pancreatitis. I'm not aware of anything to do with the prostate. And the Waterloo score, I think that's to do with pressure sores. So again, not the right scoring system for this question here. So I'm going to move on to the next question, and then we'll have a chat about prostate cancer. So again, another 60 seconds. And this is our last question, so please do participate if you're able to. Perfect. Thank you again for answering here. So what do we have here? We've got a 60-year-old man and he's worried about prostate cancer. His neighbour's just recently been diagnosed, so he's worried. He's got no symptoms, but he's asking for a prostate-specific antigen, so a PSA blood test, as someone's recommended that he ask for this. And now the question is asking which of the following things can influence the result and therefore should be avoided before taking his blood sample. This is a slightly odd question. It's a bit of a convoluted question. So PSA is notoriously quite inaccurate in the sense that a high PSA doesn't mean you've got prostate cancer. And obviously prostate cancer can exist without a high PSA level. So patients must be carefully counselled on how to interpret that result. And notably, we don't do PSAs on asymptomatic people under the age of 50 because prostate cancer is rare under the age of 50. However, NICE guidelines do say that anyone over the age of 50 that is requesting a PSA should be offered a PSA. So he is falling into that category of it's absolutely fine to offer him a PSA as long as we appropriately counsel him on what that might mean. But anyhow, the question is asking, what do we tell him before taking his blood test? And the correct answer here is he should avoid ejaculating for 48 hours before sample collection. Now, talking about prostate cancer is the #1 cancer amongst men in the UK. And like I said, it is uncommon in men less than 50 years of age. In terms of symptoms that we're thinking of lower urinary tract symptoms, so they might be up during the night to pee, they might be peeing more often, they might have uncomfortable urination, they might have hematuria, and we want to think about red flag symptoms. So weight loss and bone pain, I would say, are red flag symptoms. Prostate cancer can commonly metastasize to the bone, and it commonly causes things like back pain that can be due to metastasis to the bone. So don't ignore lower back pain and getting up to pee during the night in elderly people. That could very well be prostate cancer. And we should always perform a digital rectal examination of the prostate. And what we're looking for here is the prostate asymmetrical? Is it enlarged? Does it feel craggy? Does it feel firm? And we want to describe that in our referral letter to urology. So anyone that's got an abnormal prostate exam, we'd refer to urology. So it's really good to get in the habit of being able to describe what you've felt and being able to associate that with the symptoms and why they've presented. In terms of investigations, we would do a PSA on anyone that were suspicious of prostate cancer or anyone over the age of 50. And there's an arbitrary cutoff of greater than 4 micrograms per litre being abnormal. Now, as I said, bear in mind an elevated PSA can occur independently of any cancer. So patients that have a high PSA don't necessarily have cancer. And PSAs elevated in many non-malignant conditions. It also goes up after vigorous exercise and it also goes up after ejaculation. Hence the reason that we would ask this patient to refrain from ejaculating for at least 48 hours before he gives the blood sample. And obviously if the PSA is elevated, we're worried about prostate cancer, we would ask them to have a biopsy, and the biopsy would confirm and grade the diagnosis. So the last question was talking about grading, and the grading system we use is the Gleason score. And basically what we do is we take 5 biopsies from the prostate and we take the kind of architecture from 2 of the biopsy areas. We add these scores together and we divide it by 10, and this gives an overall grading. So the higher the grading, the worse the prognosis essentially. So low grade being less than 6 or lower, intermediate being 7, and high grade being 8 to 10. Now, sometimes it comes back as indeterminate. So that might be there's not enough tissue there, or we're not able to see the architecture. So in that case, the biopsy would possibly be repeated. And in terms of treatment of prostate cancer, some men will die of something else and will have prostate cancer in the background. So in some patients, it's appropriate to just do observation, repeating their PSA every 6 months, just to monitor any prostate development. If the PSA was rising exponentially, we might think about more invasive treatment options. But a lot of men do have prostate cancer. It doesn't cause them any particular problems and they die with it rather than of it. If we want to treat prostate cancer, there is a myriad of treatments. So we can do brachytherapy, we can do radiotherapy, we can remove the prostate entirely, we could do hormone therapies, and we can do chemotherapy. And prostate cancer can be cured, and the prognosis is pretty good for prostate cancer. And the prognosis seems to be correlated with the Gleason score. So the higher the Gleason score, the worse the prognosis essentially. So if you've got a very low Gleason score, you've got a great prognosis, and prognosis is normally kind of determined by 10-year survival. So you can see there that if you have a Gleason score of less than 6, your 10-year survival is 86%. So that's really fantastic. And it only drops to about 34 to 62%, even if your score is very high. In terms of complications of prostate cancer, the complications are, as we've seen in those questions, urinary retention. So that last gentleman, he had a retention because we knew he had a prostate cancer. It also predisposes you to urinary tract infections, and obviously any cancer can metastasize, and prostate cancer commonly metastasizes to the bone. And a lot of the complications can be treatment induced. So if we're giving somebody chemotherapy, radiotherapy, quite often bleeding and erectile dysfunction are common side effects of the treatment itself. So that's a wee overview of prostate cancer. So we have come to the end of our lecture on single best answers in urology. If you've got any questions, you can email us at info@quesmed.com. We do have an Apple app and an Android app. Feel free to download those and feel free to sign up for more of these single best answer sessions. Now, Prayesh has just popped a wee feedback link in the chat box. I'd be super grateful if you could fill that out. Good, bad, or indifferent. It's great to hear your feedback. Thank you so much for participating in the questions and answers there. Hopefully that was useful to you, and hopefully we'll see you again for the next Quesmed lecture. So thank you so much for your attention, and best of luck with med school. So